Okay. Sometimes it's not easy, but sometimes you're lucky, you go in immediately. And there, see, that is, I'm under the muscle, but it still looks as if I'm subcutaneous. So just very small aliquots I put there, and you can also push it and be very gentle. Maybe 0.1 or 0.2 I put in total, right, Felipe?
Yes, 0.2.
Yeah. So it's just a little bit, just to enhance this area, because although the rheology of the product is very good, it will not attract so much water. It will attract a little bit of water, doesn't act like a huge sponge, or like Restylane will not leave a blue haze, but will attract a little bit. So we bring them back after 2 weeks and maybe necessarily add more in my practice. And if the patient can pay, I also combine it with PRP. So that will be the best results, because then I say I'm also doing the skin conditioning. And I like also this area because now we're talking about multimodal approach to also treat this area with radiofrequency microneedling as a non-surgical adjunct. The lower lid, and it's a little bit strange to say that as a plastic surgeon, I try not to operate if I don't have to, because once you do an operation on the lower lid, you have to do a cantoplexy. If you cannot do a cantoplexy, you're an idiot to do this. I'm sorry to say it, because you can get a scleral show and you don't know how to fix it. The patient goes to someone else and then starts crying, you get a bad name. If you can do a cantoplexy, you should do it. But if you're doing a cantoplexy and you're making the patient look like a mouse, the patient will not be happy. The eyes will be very small, or like a cat. So you have to show them, do you want to look like a cat or a mouse for a long time? Then we have to do a cantoplexy if they have a lot of fat, if they have a lot of problem, then we do that, of course. But in mild to even moderate cases, I don't do a lower eyelid procedure. I just do a non-surgical procedure. And I think it's better to know when not to cut than to cut when you don't have to. And you see this patient, we put the post cream. Felipe can send everybody what the ingredients of this post cream. It looks very well. I put it on and I leave it to stay there for some time. And I push with the gauze. I don't rub all the time. I push with the gauze to let the platelets have some time to aggregate. Is that clear?
Yeah, I think we have some questions. So I'm going to stop sharing the screen because now the technique is seen. So questions. Russian lips, cannula lips. Yeah, please give me detail of Yahoo. Okay, we are learning how many milliliters, how ml do you inject per SUF, Ali?
So I try to be economical. So what you can do, if it's a very severe case, you can use, I think it's good to at least you have 1 ml of deep and 1 ml of basic. You can do both sides. So you do 0.5 ml for the SUF and the medial side, and then you have 1 ml left for both sides. To do it. If you have a severe case, of course, you need more than that. And so, to make a real difference, you can use 1 ml per side for the medial, the lateral SUF and the medial cheek fat, and then divide 1 ml of basic or lips for the tear trough. So if the patient can pay, you use 3 mLs. If it is the the budget is a problem and they're, like milking an ant, then you use 2. Because I don't know how it is here, here we ask like, yeah, I think, or sometimes you bring them back and that is what we do. But I don't think that you will reach a significant result on both sides with only 1 ml.
So there is another question. I'm going to switch on questions. So the products that he used, on the first one, you use Hyabel Deep, and the second one with the cannula, it was Hyabel Basic.
Yes.
How long does the product last? Ali, I leave it to you.
It will last at least 2 weeks. No, it will last. I think it outruns the most of the. I mean, we have to be honest, okay? Anywhere from, if you are a very heavy smoker who sits in the sun every day, the product will not last more than 6 months. In a normal patient, the product will last hopefully from 9 to 12 months. They will notice something, and then will gradually after a year become less. But even some patients, it can last beyond 14 to 16 months. But typically, I think that if you tell the patient, you know, it will last somewhere hopefully more than 9 months if they don't smoke, then you under promise and over deliver. But in my I don't have any huge affiliations with any of the companies, but I think that this product stays longer than the Merz range, and definitely as long as the Juvederm range, the Terosial range. And I think that there are products on the market which I've used, like Princess and Chroma, and they really stay very short. And like a product like Volbella, which you get problems because they stay so short because they have reduced the HA content of the product, and that stays very short. That I don't hardly ever use anymore. But I think that the longevity of the product is as good as any of the top fillers.
There is another question: did you do anesthesia first before injecting or not?
I do an anesthesia about. I put a combination of lidocaine, tetracaine, and so a triple anesthesia cream. We put it on, which is stronger than EMLA. I use it also for my laser clients. So we put that on. You know, it's also good as a placebo effect, and people are happy about it. But the products have lidocaine in them, so the cream that you put on is actually just for the skin injection, only for when it goes in. And I make it a point not to make too many holes. And there's guys who are propagating a so-called Fern technique or whatever technique, and they're using the patient as a pincushion. You know, we are not tailors who put all kinds of needles in patients, stick them like pincushions. So I try to put very few needle insertions and be very careful, and that's what we need to do.
There is one question a little bit out of the subject, but maybe if you can answer fast, because I don't like to give any unanswered question. Is how do you add PRP?
You take a connector, and then you go and then you add like this with the connector.
Okay.
But I can tell you the exact way how to do it and the exact dose, but then I have to kill you. Because it's my secret recipe. You know, Coca-Cola does not give away the recipe. But
I know you
say yeah, you know, they just say it tastes good. But no, just to be friendly, you know, you take PRP, you take 4 milliliters of PRP. What I do, I just mix, for example, when you're doing PRP for the neck, I mix 1 milliliter of either the meso or the Hyabel, one of the low G prime ones, and I mix 1 or 2 mils of PRP with it with a bit of lidocaine, and you bring that also. You can bring it there, and the PRP. What you do for the tear troughs, you can combine it when you're doing PRP for the face and for the neck. You can put just a little bit of it to improve the skin. It's a skin conditioner.
Thank you. So someone wants to make a question about Ultra. Yes, you can do it. Please do it in the chat or directly on the Q&A. And we are going to see the second patient of Dr. Ali for the tear-through with another approach, this time with Hayabel lips. So I'm going to share my screen. This is shorter as the one that just we saw. And I'm going to close all the boxes, so we will see only the video this time. I do not know why it happened. So, Ali, can you see the face?
Mm-hmm.
Perfect. So I will move this here so I don't.
Okay, we're injecting again in the tear trough from lateral. You see the cannula there.
But remember, she had something before, so this is why we decided here.
Exactly. So she has had filler before there, and we decided to get away from there. She also has a big vein over there. So we're taking it very, very gently to inject there. And later on, do you have the before and afters of these patients to show?
Yes, I can show it. I can show if we have the time, we can show it on the webinar. Yeah.
But you can go quickly with this one. Just move it forward.
I can go quick. I know. I know. Here.
Just put it down here and then move it. Yeah.
I go two times faster. I hope it's okay with everybody.
Yeah. Maybe a little faster. Because they've seen it most on the one before. You can see I'm just under the skin. Here we're just using a subcutaneous technique. You see? Yeah. We're above the infraorbital ligament. So the orbicularis retaining ligament is a defining ligament of that circles the orbit. So with this, you stay above the orbicularis retaining ligament because it's a very tough ligament. So you're under the orbicularis but above it, and you don't want to mess around too much there because it can be quite a tough ligament. See there? And if they have so much skin, I also ask them, and I think maybe Dr. Ozenturk agrees with me, if you ask them in the morning, you all wake up with puffy eyes, your eyes are very swollen. If you inject filler there, you get in trouble because filler will act like a sponge, attract more water. Then what will happen, it will be a catch-22 when the filler together with water will impinge on the lymphatic supply. The lymphatic supply will become blocked. There will become even more water there, and the patient is going to make your life miserable. The only thing you can do then, the only thing you can do then is do IPL treatments to make the swamp dry. But then you're already in trouble. So better stay out of this kind of trouble. Do you agree, Dr. Ozenturk?
Yeah, totally. I agree with you. The lymphatic drainage around the orbital rim is very important, and really there are many cases with this problem. I try to solve the problem sometimes, from time to time.
And it's worse in smokers.
Yeah.
So
your technique is very good. I might tell you that.
Thank you so much.
So I'm going to stop sharing. Oh, I don't know whether, here, sorry. I'm going to stop sharing the screen. So if there is any question, please do the questions on the chat or the Q&A, so either Dr. Ali or Dr. Ozenturk can answer, while I'm going to upload the before-after pictures of those two patients, because it will take some time because of the software.
Okay, so we have questions.
Yes, what is the incidence of thin defect with superficial subcutaneous relatively high G prime?
Okay, so that's a question of Ms. Dr. El Mohandes. That's a very good question because we have